My name's Claire Hartell. I'm the lead research and development radiographer at Guy's and St Thomas's Hospital. I'd like to thank Vision RT for asking me to talk today. I'm going to talk to you about how we use SGRT to improve the quality of care of our lymphoma patients at Guy's and St Thomas's. So I'm just going to run through very briefly our implementation of DIBH for lymphoma. So our rationale for using DIBH for lymphoma patients, a technique that we now employ called VMAT, butterfly lymphoma, and the work that we're planning on doing with Align RT. So for those of you that don't know, Guy's and St Thomas's is a large hospital within South East London. We're very close to the Shard, if anyone's done any sightseeing. We're actually split over 2 sites now, so we have this new cancer centre, which we've been in for a year, and we have a satellite department in Sidcup. So we have 8 Varian true beams, 3 scanners, and we also have a tomotherapy unit and a brachytherapy suite, which actually sits over on our other site at St Thomas's. So we're covering a large population of just under 1.7 million within South East London. So we first implemented Align RT at our centre for the implementation of DIBH for left-sided breast patients. So we had 2 systems installed in July 2014, and those of you who've had systems installed will know it's very quick, and we were treating our first patient the following month. And once we'd set up that service, our lymphoma clinicians very quickly realised that they could use this for their patients as well, and it would be beneficial. The reason being that there's quite a lot of challenges when treating mediastinal disease with radiotherapy. So for lymphoma patients, radiotherapy is actually integral to their curative treatment, and about 1/3 of patients will receive radiotherapy as part of their treatment plan. And the mediastinum is the most commonly irradiated site. And this can be problematic because of the proximity of the heart and the lungs and breast tissue and how close it is to the target volume. It's well recognised that the patients that are cured of lymphoma then go on to have excess mortality due to late side effects. And this lymphoma is the most common cancer among 15 to 30-year-olds. So these are patients that we cure of disease, but then go on to live for several tens of years. So we need to minimise these late toxicity as much as we can. So it's been shown that patients that had mediastinal radiotherapy for Hodgkin's disease below the age of 41, they have a 2 to 7-fold increase in the risk of developing ischemic heart disease, valvular disease, and congestive heart failure. And this is compounded by the fact that they're having chemotherapy, anthracycline-containing chemotherapy, which is cardiotoxic. So we need to do all we can to reduce the cardiac dose for these patients. So the rationale for using DIBH for these patients is to reduce the dose to these organs at risk by exploiting the changes that happen when the patient goes into breath hold. And also the fact that they're holding their breath means that we can reduce or even eliminate respiratory motion. So what is it that is happening when the patient takes a deep breath in? So their lungs expand, and that allows us to irradiate relatively less lung tissue. The chest wall moves upwards and outwards, and this pulls the mediastinum away from the spinal cord and esophagus. The diaphragm moves down and flattens, and this elongates the mediastinum. And you can see between these 2 slides just how narrower the mediastinum becomes when the patient takes a breath in. And again, this is demonstrated in these 2 rendered images from the free breathing to the DIBH. It just brings your target volume into a much narrower position. And the effect is that the elongation of the mediastinum means that the heart moves downwards as well, and this can have a separation effect then between your PTV and your heart, which means that you can reduce that cardiac dose even further. So the evidence was there that the DIBH for lymphoma patients was beneficial. You could reduce cardiac and lung doses when the patient was in DIBH. And although the reductions may only be small, they may be clinically significant, and this is, as I say, a young group of patients, so we need to do all we can, even if it's just small gains. This graph here is by a paper by Darby et al., which actually shows that for every grey increase in mean heart dose that the patient receives, they have a 7.4% increase in having a major cardiac event, and there's no threshold to that. So the higher the dose gets, the greater that increase in the risk of cardiac event. Now, about the same time, there was lots of evidence, papers coming out about a new rapid arc technique, treatment delivery technique, that was using non-coplanar partial arcs to deliver radiotherapy to the mediastinum that allowed you to reduce the dose to the heart and lungs, and also reduce the low dose bath that can be seen with full arc techniques, which reduce the low dose bath to the lungs and to the breast tissue in female patients. So I shall attempt to show you how we deliver this. So we have a partial post-oblique partial arc, an anterior partial arc, and a contralateral partial arc, and then we go back round the other way. And we rotate the patient through 90 degrees, and we do two sagittal arcs. So this is a slide from one of my colleagues, Professor McHale, who's a lymphoma clinician in our department, which just shows you the difference with if you are delivering full arc radiotherapy with free breathe, you can see the low dose bath to the lungs and encroaching on the breast tissue, and then the effect that actually asking the patient to go into breath hold has on elongating your dose distribution, the mediastinum, and by the time you've used a butterfly VMAT technique with your DIBH, you've got a very narrow dose distribution, limiting the dose to those other critical structures. In case anyone's struggling to understand why this is called the butterfly technique, because I didn't get it for a long time, I think if you turn a butterfly upside down and close one eye and vaguely imagine those arcs, it looks a bit like a butterfly. However, my colleague is in the audience somewhere who's a physicist who went, it's to do with the dose distribution, but I cannot see that dose distribution looks like a butterfly. Maybe that's the difference between radiographers and physicists, amongst many. So for our patients, the way we prepare our patients at consent, they're given an information sheet about DIBH. They're asked to go away and practice going in and out of DIBH. When we see them for pre-treatment, so we still do a free breathing and a DIBH scan, which I'll mention again in a minute. But what we found was we used to do the free breathing scan, and then we'd see whether the patient could go into DIBH or not. What we found was that the patient was actually quite anxious about this whole process and whether they would or wouldn't be able to do it. And so by the time we'd done their free breathe scan and came to do the DIBH scan, and they were more relaxed because they realised they could actually do it, they were going to achieve it, we had to change that. We coached them up front. We call it coaching. We don't teach the patients how to breathe. We're checking that they can hold their breath, that they can repeatedly hold their breath, that they can hold it for 20 to 30 seconds. This group of patients compared to breath patients tend to be able to hold their breath for longer. They tend to be younger and fitter. That might just be the demographic in our area, but that's what we find with these patients. So we do two scans, one after the other, free breathing and DIBH. We record the difference in the tattoo positions from free breathe to DIBH, and the doctors plan on the free breathing. They contour the free breathing and the DIBH scans. So what the doctors found was they use the PET for their contouring. The PET is done in free breathe. If they use the free breathe PET to then try and contour a DIBH scan, they found it very difficult to work out where that active disease was. So they go through a process of contouring the free breathe with the PET, and then once they've got very used to the patient's anatomy, then they go and outline the DIBH scan. We also do have instances, more with our breast patients than lymphoma, when patients can't actually achieve DIBH for treatment, we will revert back to the free breathe plan, and the scan is already there, it's already been contoured, so that's a very quick turnaround. Planning is planned as a 5 ml margin for the DIBH patients for a CTV-PCV margin. So our workflow is very quick. These patients are in a 15-minute appointment slot. We set them up in free breathe. We assess their DIBH position with the measurements that we took at CT. We shift to the Plans ISA Centre. We switch on Align RT, monitor the patient. We perform a cone beam in breath hold. These patients tend to be able to do the full 360 cone beam in 2 breaths, perform an online correction, acquire a reference image, and then monitor and treat with DIBH from then on. The 8 arcs are actually very short, so the patients do each arc on 1 breath hold. So actually treatment delivery following cone beam is pretty quick. So Align RT has allowed us at GSTT to offer a DIBH service, which was very quick and easily implemented. It has enabled our patients to be able to benefit from DIBH in a non-intrusive way without restricting patient eligibility. Going back to Jackie's talk, if you've ever use the spirometry system yourself, which I've had a go of, it's it's quite difficult, and you really cut out the number of patients that will be eligible to have DIBH by having quite a complex way of achieving it. So this opens up the accessibility for DIBH for a lot more patients for us. We, as radiographers, have the reassurance of monitoring a large surface area. We're not just looking at a block on a surface. And it's a very quick setup. It's a very quick treatment time. So it has enabled us to be one of the first sites in the UK to deliver DIBH butterfly VMAT for lymphoma patients, which has meant that we are now able to offer a technique that reduces the dose for patients to the heart and lungs and reduces the dose to breast tissue in these young female patients. And in the future, we're planning on doing what everyone else is doing, actually. So we're looking at our setup corrections with Align RT and comparing them to our cone beam. And just to see, actually, for these patients, we're never going to eliminate using cone beam. We know that's important, but can we reduce the amount of concomitant dose these patients are receiving by saying that we can cone beam them for a certain number of fractions, and then once we're happy that we're in the right place, we can then use Align RT at intervals between cone beam verification. One other thing that we're looking at, well, amongst other things, my colleague in the audience, Chris, is actually looking at acquiring the PET CT in breath hold. So then we may be able to stop doing a free breathe scan if the doctors are then able to have a DIBH PET and contour a DIBH CT scan. So this is the things that we're working on at the minute. I'd like to thank my colleagues at GSTT for giving me a few of their slides, and thank you for listening. So actually what I should say is that DIBH isn't actually required for all patients, and butterfly lymphoma isn't suitable for all patients. So same with our breast patient, everyone goes in with, they are eligible to have DIBH, and it's only really if they can't breath hold, or they can't maintain a breath hold, or they can't understand the instruction to go into breath hold, that they then become ineligible. Sorry? We do, yeah. Yeah, it's definitely something we're looking at. We've been to visit Nottingham to see how they do tattoo-less breast setup. We take measurements because at the minute we don't use a free breathing surface to check at the tattoo level. We just check it at the treatment ISA centre. So potentially, if we started using Align RT at the tattoo, CT reference point through the tattoos, we could get away from taking those measurements, which is the difference between the tattoo position at free breathing DIBH.